What is the purpose of initial rhythm interpretation/analysis and defibrillation? To be performed as soon as possible. How often should additional rhythm interpretation/analyses occur? At 2-minute intervals. What should be the focus during additional rhythm interpretation/analyses? Delivery of high-quality chest compressions. What guidelines are followed for defibrillation energy settings? Specific manufacturer guidelines supported by regional base hospital program. Do paramedics count pre-arrival interventions into their patient care? No, but it can be considered and documented. How long should paramedics complete resuscitation in a setting of cardiac arrest? A full 20 minutes. When should compressions during the charge cycle be considered? To minimize the peri-shock pause. Should the ambulance be stopped when using semi-automated rhythm analysis? Yes, to minimize artifact and the risk of an inaccurate rhythm interpretation/analysis. What factors should paramedics consider for a witnessed arrest in the back of the ambulance? Distance to closest hospital, probable cause of arrest, ability to provide adequate CPR/ventilation, shockable versus non-shockable, etc. How many full analyses should paramedics perform before deciding to proceed to hospital? 3 full analyses. What is the minimum number of analyses paramedics should provide before deciding to proceed to hospital? At least 1 analysis. What are supraglottic airways? Devices used to maintain an open airway above the glottis. What is the preferred sequence for the placement of advanced airways based on? Reduced importance on airway, ease of supraglottic airway insertion, emphasis on minimally interrupted compressions. When should a supraglottic airway be placed? When more than a basic airway adjunct is required for a VSA patient or in a prolonged resuscitation. What is the recommended rate of ventilations for adults with a supraglottic airway? 10 breaths/minute. What is the recommended rate of ventilations for children and infants with a supraglottic airway? 20 breaths/minute. When should the patch point occur for PCPs? After 20 minutes of resuscitation if considering the medical TOR. What is the purpose of the patch point? To receive advice on whether to transport, terminate resuscitation, or follow additional orders. What should paramedics do if a patient rearrests en route after achieving RUSC? 1. Pull over. 2. Initiate immediate rhythm interpretation/analysis. 3. Treat rhythm appropriately. 4. Continue transportation with no further stops. What are some early transport considerations after 1 analysis and defibrillation if indicated? Hypovolemia, hypoxia, hydrogen ion, hyper/hypokalemia, toxins, tension pneumothorax, thrombosis, tamponade. What is glucometry? Measurement of blood glucose levels. When is glucometry not indicated? In vital signs absent patients. What is anaphylactic cardiac arrest? Cardiac arrest directly related to an anaphylactic reaction. What is the indicated treatment for anaphylactic cardiac arrest? A single dose of IM epinephrine 1000. Should the administration of epinephrine delay defibrillation in anaphylactic cardiac arrest? No. What is asthmatic cardiac arrest? Cardiac arrest in a patient with asthma. Is the use of epinephrine recommended in asthmatic cardiac arrest? No. What should be the focus in asthmatic cardiac arrest? Effective ventilation and oxygenation. What is electrocution? Injury or death caused by electric shock. How should a simple electrocution be treated? As a medical cardiac arrest that responds well to defibrillation. How should an electrocution associated with significant trauma be treated? As a trauma cardiac arrest. When are subsequent pulse checks indicated? When a non-shockable rhythm or signs of life are present. How should commotio cordis and hangings be treated? As medical cardiac arrests, unless life-threatening trauma is present. What is an intravenous fluid bolus? A rapid administration of fluids through an IV. When is an intravenous fluid bolus considered? To assist with potential reversible causes without delaying transport. What percentage of newborns require assistance to begin breathing? Approximately 10%. What percentage of newborns require extensive resuscitation? Less than 1%. What are the criteria for beginning resuscitative assessment and interventions? Term gestation, good muscle tone, breathing or crying. Is this medical directive applicable to all patients under 24 hours of age? Yes. What should be done if ventilations are ineffective? Consider trying Mr. SOPA. What is the purpose of the oxygen saturation chart? To provide ideal targets for oxygen saturation levels. How should heart rate be accurately determined? By initiating cardiac monitoring. What should be done for a newborn with meconium, poor muscle tone, and breathing/crying? Suction the mouth and pharynx before the nose while ensuring oxygenation is maintained. Is routine meconium suctioning required? No. Does the administration of epinephrine IM for anaphylaxis apply to this directive? No. When is oxygen administration not required even if central cyanosis is present? When respirations appear adequate and the heart rate is greater than 100 bpm. What does Mr. SOPA stand for? Mask adjustment, reposition airway, suction mouth and nose, open mouth, pressure increase, alternate airway. What is the purpose of drying, positioning, and stimulating in newborn resuscitation? to assist the newborn in beginning breathing. What should be assessed first in a patient that is not newly born? Respirations and heart rate. What should be done if the ventilations are ineffective? Consider trying Mr. SOPA. Where should the Predactyl SpO2 probe be applied? To the right hand. What should be done if central cyanosis is present but respirations appear adequate and the heart rate is greater than 100 bpm? Oxygen administration is not required. What is the purpose of initiating cardiac monitoring? To accurately determine heart rate. What should be done for a newborn with meconium, poor muscle tone, and breathing/crying? Suction the mouth and pharynx before the nose while ensuring oxygenation is maintained. What are the signs of respiratory distress? Sternal retractions, grunting, nasal flaring. How should oxygen be administered in case of respiratory distress? By mask at 5 to 6 liters per minute or by cupping a hand around the oxygen tubing and holding it 1 to 2 centimeters from the patient's face. How should the administration of oxygen be adjusted? Slowly withdraw as the patient's color improves. What is the goal for oxygenation during RUSC? Target SpO2 of 94 to 98%. Why should oxygen administration be continued even if SpO2 values are ideal? To stabilize the patient. What is the recommended ventilation rate for adults post-RUSC? Approximately 10 breaths per minute. What is the recommended ventilation rate for children and infants post-RUSC? Approximately 20 breaths per minute. What is the target SpO2 range post-RUSC? 30 to 40 mmHg. What should be avoided when it comes to ventilation post-RUSC? Hyperventilation. What should be avoided when it comes to SpO2 levels post-RUSC? Hypoventilation. What does a low SpO2 level post-RUSC may reflect? Metabolic acidosis. What is the recommended fluid therapy post-RUSC if chest auscultation is clear? 10 ml per kilogram 0.9% NaCl fluid bolus. What is the maximum amount of fluid that can be administered post-RUSC? 1000 milliliters. What is the target SBP post-RUSC? Greater than or equal to 90 mmHg. What is the purpose of fluid therapy post-RUSC? To maintain blood pressure. What is the purpose of 12-lead acquisition in the treatment of cardiac ischemia? To identify STEMI and proceed nitroglycerin consideration. What is the preferred method of interpreting a 12-lead ECG? Manual interpretation. What is the recommended time frame for performing a 12-lead ECG? Within the first 10 minutes of patient contact. What should the paramedic do if they are unable to perform a 12-lead ECG within the first 10 minutes? Document the barriers that prevented achieving this goal. What additional steps should be taken if an inferior STEMI is identified on the 12-lead ECG? Complete a minimum V4R to rule in or out a RVI before considering nitroglycerin. Why is it important to perform a V4R in patients with inferior STEMI before administering nitroglycerin? These patients are often preload dependent and nitroglycerin may cause significant hypotension. What is the proper placement of electrodes for a complete 15-lead ECG? V4 equal V4R, V5 equal V8, V6 equal V9. Is it necessary to repeat the 12-lead ECG once a STEMI has been identified? No. What is recommended if there is no evidence of STEMI on the 12-lead ECG? Serial 12-lead ECGs. What is the therapeutic index of ASA? 80 to 1,500 milligrams. Is ASA a safe medication? Yes. What should the paramedic do when administering ASA in the context of cardiac ischemia? Apply the medical directive as if no care had been rendered prior to arrival. What is the purpose of nitroglycerin administration in the treatment of cardiac ischemia? To relieve chest pain and improve blood flow to the heart. What is the maximum dose of nitroglycerin that can be administered by paramedics? The therapeutic dose. What should the paramedic ensure when administering nitroglycerin? Correct dose and administration of the medication. What should the paramedic consider when administering nitroglycerin to patients with inferior STEMI? The potential for significant hypotension due to preload dependence. What should the paramedic do if there is no evidence of STEMI on the 12-lead ECG? Consider other treatment options and continue monitoring the patient. What is the purpose of serial 12-lead ECGs? To monitor for any changes in the patient's condition. What are the conditions for nitroglycerin use? Prior history or established IV. What is the definition of prior history? Previously authorized or prescribed by a certified medical doctor. Why is it important to assess the if for patency before administering nitroglycerin? To ensure the if is functioning properly for administration. Who can administer nitroglycerin with an established if? PCP with autonomous if certification. What is the relationship between me and CHF? STEMI may cause or exacerbate CHF. How many doses of nitroglycerin should be administered in STEMI? Maximum of 3 times 0.4 milligrams doses. What is the purpose of reducing the number of nitroglycerin doses in STEMI? To reduce adverse outcomes associated with liberal nitroglycerin use. When is CPAP appropriate for patients with cardiac issues? if they meet the criteria outlined in the CPAP medical directive. What should be considered when using nitroglycerin in patients with tachycardia or SBP close to 100 mmHg? Use with caution. Can nitroglycerin be administered for isolated posterior STEMI? Yes. What should be done in the case of right ventricular STEMI? No nitroglycerin should be administered. What are phosphodiesterase inhibitors used for? Treatment of pulmonary hypertension and congestive heart failure. How are phosphodiesterase inhibitors categorized? Phosphodiesterase 5 inhibitors. What are some examples of phosphodiesterase 5 inhibitors? Viagra, Levitra, Cialis, Revatio, sildenafil, tadalafil, vardenafil, udenafil, avanafil, lodenafil, myrodenafil, acetaldenafil, aldenafil, benzimidenafil, Zapronest, Acarian. When would a decision to administer ASA be made? If myocardial ischemic symptoms/acute coronary syndromes resolve prior to the arrival of paramedics. What factors are considered when making a decision to administer ASA? Patient assessment and critical thinking. What happens if a patient's vital signs fall outside the medical directive's parameters? The patient can no longer receive the medication. Can the patient receive medication if their vital signs return to acceptable ranges? No, given the risk for recurrent decompensation. What is acute cardiogenic pulmonary edema? Fluid accumulation in the lungs due to heart failure. How many doses of nitroglycerin can the patient receive? Maximum of 6 doses of either 0.4 mg or 0.8 mg. Can the patient receive 6 doses for both pulmonary edema and cardiac ischemia symptoms? No, the patient cannot receive 6 doses for both conditions. Is an initial 12 or 15 lead acquisition and interpretation required for nitroglycerin administration in this medical directive? No, it is not required, but advisable to do so. Why is an initial 12 or 15 lead acquisition and interpretation not required for nitroglycerin administration? Right ventricular infarctions do not generally present with acute pulmonary edema. What should be done if nitroglycerin administration results in hypotension in patients with acute cardiogenic pulmonary edema? A fluid bolus is permitted, and once the patient is normotensive, discontinue the fluid bolus, and withhold further doses of nitroglycerin. Can a fluid bolus be given despite the presence of crackles in the lungs? Yes, if a PCPAIV paramedic is attending. What is the purpose of acquiring and interpreting a 12 or 15 lead ECG? To assess the patient's cardiac condition. When should a 12 or 15 lead ECG be acquired and interpreted? As soon as possible or when practical to do so. What is the cause of acute cardiogenic pulmonary edema? Heart failure leading to fluid accumulation in the lungs. What is bronchoconstriction? Narrowing of the airways in the lungs. What are the symptoms of bronchoconstriction? Wheezing, coughing, dyspnea, decreased air entry, silent chest. When is epinephrine 1000 IM indicated? When the patient is asthmatic and BVM ventilation is required. When should epinephrine be administered immediately? When salbutamol has had no effect or due to the severity of the patient's condition. What are the indications to administer epinephrine? Suspected bronchoconstriction in asthma, COPD, and other causes. What is the preferred route of administration for salbutamol? MDI. When should nebulization be considered for salbutamol administration? If the patient is unable to accept or cooperate with MDI administration. What is the maximum number of doses for nebulized salbutamol? 3 doses. How many sprays of MDI salbutamol should be delivered for a complete dose in pediatric patients? 6 sprays. How many sprays of MDI salbutamol should be delivered for a complete dose in adult patients? 8 sprays. Under what circumstances would less than the full dose of MDI salbutamol be delivered? Unusual circumstances. What is the technique for administration of MDI salbutamol? Provide 1 MDI spray, followed by 4 breaths to allow for inhalation. How long does it take to deliver a full adult dose of MDI salbutamol to a patient breathing at a rate of 32 breaths per minute? 1 minute. Do the indications for epinephrine change based on the ability to administer salbutamol? No. What is the concentration of epinephrine 1000? 1 milligram per milliliter. What is the maximum number of doses for nebulized salbutamol? 3 doses. What are the common causes of bronchoconstriction? Asthma, COPD, and other factors. What are the potential complications of bronchoconstriction? Wheezing, coughing, dyspnea, decreased air entry, silent chest. What are the potential complications of bronchoconstriction? Wheezing, coughing, dyspnea, decreased air entry, silent chest. What is the recommended use of MDI and spacer device? Single patient use device. What precautions should a paramedic take when using nebulization? Use PPE to prevent contagion spread. Can dexamethasone manufactured for IV/IM use be administered orally? Yes, it can be administered orally. What is the preferred route of administration for dexamethasone? Oral route. When should dexamethasone be given IM/IV? only if the patient is extremely short of breath in suspected respiratory failure, and all other care has been provided. Can dexamethasone be used in conjunction with other medications? Yes, it can be used with salbutamol, epinephrine, and CPAP. What are the priority treatments when using dexamethasone? Salbutamol and epinephrine. What is the contraindication to steroids when using dexamethasone? Contraindication only applies to systemic steroids, and not inhaled or topical steroids. Are inhaled steroids absorbed systemically? No, inhaled steroids are specific to lung tissue, and do not contribute to systemic absorption. Is COPD underdiagnosed in Canadians? Yes, COPD is underdiagnosed in Canadians. What is a significant risk factor for the development of COPD? Smoking is a significant risk factor for COPD. What is pack years? A way to measure smoking exposure based on the number of years smoked and the amount smoked per day. Who would be considered for dexamethasone among undiagnosed patients? Undiagnosed patients who smoke or previously smoked and have 20 pack years. What is the purpose of the medical directive? To administer diphenhydramine for moderate to severe allergic reactions. What is anaphylaxis? A life-threatening allergic reaction. What is the importance of timely administration of epinephrine in anaphylaxis? Delays in administration are associated with greater mortality. How is epinephrine 1,000 administered in anaphylaxis? Via the IM route only. Why should IV access be considered after IM administration of epinephrine? To reduce the chance of inadvertently administering the medication via the IV route. What should be assessed in addition to skin findings in patients with allergic reactions? All body systems to determine the most appropriate treatment plan. Is urticaria alone an indication for administration of epinephrine IM? No, the patient must present with at least one other sign or symptom involving another organ system or severe symptom. When should diphenhydramine be administered? It should always follow the administration of epinephrine as outlined in the medical directive. How can an anaphylactic reaction be differentiated from a localized allergic reaction? Based on detailed history and recognition of presenting signs and symptoms post possible exposure to a possible allergen. What are the possible body system involvements in anaphylactic reactions? Integumentary, cardiovascular, respiratory, gastrointestinal. What are the possible signs and symptoms of integumentary involvement in anaphylactic reactions? Hives, itching, flushing, swelling, angioedema. What are the possible signs and symptoms of cardiovascular involvement in anaphylactic reactions? Increased heart rate, decreased blood pressure, syncope, decreased level of consciousness, hypoxemia. What are the possible signs and symptoms of respiratory involvement in anaphylactic reactions? Shortness of breath, wheeze, cough, stridor. What are the possible signs and symptoms of gastrointestinal involvement in anaphylactic reactions? Cramping, nausea, vomiting, diarrhea. What is the difference between a minor to moderate allergic reaction and an anaphylactic reaction? Anaphylactic reactions are more severe and life-threatening compared to minor to moderate allergic reactions. What is a moderate to severe allergic reaction? An allergic reaction that can be localized or systemic. What is a localized reaction? An allergic reaction that involves one local area or one body organ system. What is a systemic reaction? An allergic reaction that involves symptoms in more than one body organ or system. What is degranulation of localized mediators? The release of chemical mediators in a specific area during an allergic reaction. What is degranulation of systemic mediators? The release of chemical mediators throughout the body during an allergic reaction. What should be considered a severe allergic reaction? Severe symptoms to a single body system, such as the respiratory system. What is degranulation of localized chemical mediators? The release of specific chemical mediators in a specific area during an allergic reaction. What is degranulation of systemic chemical mediators? The release of various chemical mediators throughout the body during an allergic reaction. What is a biphasic reaction? A reaction that occurs within 72 hours of the initial symptoms, resolving without further exposure to an allergen. Who are considered high-risk patients for allergic reactions? Very young and very old individuals, those with a history of asthma, cardiovascular disease, or mast cell disease. What is the primary treatment for allergic reactions? Diphenhydramine, which relieves symptoms but does not prevent or relieve upper airway obstruction, hypotension, or shock. What is the primary treatment for severe allergic reactions? Epinephrine, which increases blood pressure, prevents, and relieves hypotension, decreases upper airway obstruction, wheezing, urticaria, and angioedema. What secondary treatment should be considered after administering epinephrine? Diphenhydramine via IM or IV, NP or NIV fluids as per medical directive. What secondary treatment should be considered after administering epinephrine? Diphenhydramine via IM or IV, NP or NIV fluids as per medical directive. What secondary treatment should be considered after administering epinephrine? Diphenhydramine via IM or IV, NP or NIV fluids as per medical directive. What secondary treatment should be considered after administering epinephrine? Diphenhydramine via IM or IV, NP or NIV fluids as per medical directive. What secondary treatment should be considered after administering epinephrine? Diphenhydramine via IM or IV, NP or NIV fluids as per medical directive. What is the priority treatment for severe croup? Epinephrine. What can be considered as a treatment for severe croup? Dexamethasone. What should be considered as a treatment for mild to moderate croup? Dexamethasone. What can be attempted prior to initiating nebulized epinephrine? Moist/cold air. In what type of patients is croup occurring more frequently? Older patients including adults. What is required to consider treatment under this medical directive for croup in older patients? A patch to a BHP. What type of steroids are contraindicated in croup treatment? Systemic steroids. Are inhaled steroids contraindicated in croup treatment? No, they are specific to lung tissue and do not contribute to systemic absorption. Will an additional dose of systemic steroids improve the condition of a patient who has received them in the past 48 hours? No, due to their long half-life. What does the condition of age, childbearing years refer to? Approximate ages of 14 to 50 years. Are paramedics authorized to perform internal vaginal exams? No, for any reason. In what situations should paramedics consider inspecting the perineum? When history suggests ruptured membranes or umbilical cord prolapse, when the patient is in labor and reports an urge to push or bear down, when the patient is near term and has a decreased level of consciousness, and when there is heavy vaginal bleeding and the patient is hypotensive or in shock. What are the signs of second-stage labor? Contractions every 2 to 3 minutes lasting 60 to 90 seconds, contractions associated with maternal urge to push or move the bowels, heavy red show visible at the vaginal opening, and presenting part or bulging membranes visible at vaginal opening and or perineum bulging with contraction. What are the signs of imminent birth? Crowning or other presenting part is visible. In primates, the presenting part is visible during and between contractions with contractions less than 2 minutes apart. In multiples, contractions are 5 minutes apart or less with any other signs of second-stage labor present. What is a complicated delivery? Shoulder dystocia, an inability of the fetal shoulders to deliver spontaneously. What is shoulder dystocia? Fetus's body does not emerge with a contraction following the delivery of head. What is a turtle sign? Fetal head retracting firmly against the perineum following a contraction. What is the McRoberts maneuver? Flexing the maternal thighs onto the abdomen to assist with delivery. What is suprapubic pressure? Applying steady firm downward pressure with the heel of the hand just behind the maternal symphysis pubis. What is the Gaskin maneuver? Position change to hands and knees to attempt delivery of the posterior shoulder. What is a breech delivery? Delivery of a fetus with the buttocks or feet presenting first. What should paramedics do in the presence of a breech presentation? Remain relatively hands-off until the fetus has delivered to the umbilicus to avoid stimulating premature respiration. What should paramedics do if the head does not deliver within 3 minutes of the body? Attempt the Morisot, Smellie, Veit maneuver. How is the Morisot, Smellie, Veit maneuver performed? Lay the neonate along one forearm, exert gentle pressure on the neonate's face to increase flexion, and push up on the occiput to aid flexion. What is the purpose of the McRoberts maneuver? To assist with the delivery of the fetus's body in cases of shoulder dystocia. What is the purpose of suprapubic pressure? To help dislodge the fetus's shoulder during delivery. What is the purpose of the Gaskin maneuver? To attempt delivery of the posterior shoulder in cases of shoulder dystocia. What is the purpose of remaining hands-off in a breech presentation? To avoid stimulating premature respiration in the fetus. What is the purpose of allowing the head to deliver spontaneously? To avoid hyperextension of the neonate's head during delivery. What is the purpose of the Morisot, Smellie, Veit maneuver? To aid in the delivery of the neonate's head if it does not deliver within 3 minutes of the body. How should the neonate be positioned for the Morisot, Smellie, Veit maneuver? Lying along one forearm with gentle pressure on the face and fingers hooked over the shoulders. What is the recommended position for the patient during the McRoberts maneuver? Lying flat with the maternal thighs flexed onto the abdomen. What is the recommended position for the second paramedic during the McRoberts maneuver? Placing their hands slightly above and just behind the maternal symphysis pubis. What is the recommended action for the second paramedic during the McRoberts maneuver? Exerting steady firm downward pressure with the heel of the hand. What is the purpose of lifting the body at an arc during delivery? To assist the fetal head to pivot around the symphysis pubis, and allow the face to be born slowly. What should a second paramedic do if a cord prolapse is present? Apply suprapubic pressure. What is the recommended position for a patient with a cord prolapse? Knee chest position or exaggerated Sims position. Describe the exaggerated Sims position. The patient lies in left lateral position with left arm lying along the back and the right knee drawn towards the chest. A pillow/wedge is placed under the left hip/buttocks to raise the pelvis and use gravity to move fetus toward the fundus. Which position is more effective at elevating the presenting part of the cord in the presence of strong uterine contractions? Knee chest position. How should a nuchal cord be managed? Slip the cord over the neonate's head or shoulders. If manual means fail, clamp, and cut the cord while the neonate is still on the perineum. What does lack of progression of labor refer to? Situation where there are signs of imminent birth but no further progression of delivery. What should paramedics do in case of lack of progression of labor? discourage the patient from pushing or bearing down during contractions, and initiate transport. When should the umbilical cord be clamped and cut after delivery? Immediately if multiple gestation is suspected, neonatal or maternal resuscitation is required, or due to transport considerations. How should the umbilical cord be clamped? Using OPS clamps in 2 places. What is the purpose of applying suprapubic pressure during a cord prolapse? To relieve pressure on the cord and prevent further prolapse. What is the purpose of the knee-chest position during a cord prolapse? To elevate the presenting part of the cord and reduce pressure on the cord. What is the purpose of slipping the nuchal cord over the neonate's head or shoulders? To relieve the cord from being wrapped around the neonate's neck. When should the cord be clamped and cut if a nuchal cord cannot be relieved by manual means? While the neonate is still on the perineum. What is the purpose of discouraging the patient from pushing or bearing down during contractions in case of lack of progression of labor? To prevent further complications and initiate transport. What should be done if a cord prolapse is present? Place the patient in a knee-chest position or exaggerated Sims position, cradle the cord in hand, replace it in the vagina, and apply manual digital pressure to the presenting part. What is the purpose of elevating the presenting fetal part off the cord during a cord prolapse? To maintain blood flow to the fetus and prevent compression of the cord. What is the purpose of clamping and cutting the cord in case of multiple gestation? To separate the neonates and facilitate individual care. What is the purpose of clamping and cutting the cord if neonatal or maternal resuscitation is required? To provide immediate access for resuscitation procedures. What is the purpose of clamping and cutting the cord due to transport considerations? To facilitate safe transportation of the neonate and mother. What is the recommended distance to cut the umbilical cord from the neonate's abdomen? Approximately 15 centimeters. What is the recommended distance to cut the umbilical cord from the first clamp? Approximately 5 to 7 centimeters. What instrument should be used to cut the umbilical cord? OPS scissors. When should external uterine massage be performed? After the placenta has been delivered and there is excessive bleeding. How long should external uterine massage continue? Until bleeding stops. What should not be done to control bleeding? Packing the vagina. What type of pressure is required for external uterine massage? Firm pressure. What should the patient be made aware of during external uterine massage? It will be uncomfortable/painful and the reasoning behind it. When should external bimanual compression be performed? When the paramedic is unable to control excessive bleeding. Can external bimanual compression be performed regardless of whether the placenta is delivered or not? Yes. What is the potential impact of adding oxytocin in managing postpartum hemorrhage? Dramatically affecting maternal morbidity and mortality. What organization globally endorses the use of oxytocin for postpartum hemorrhage? World Health Organization. What is the potential effect of oxytocin on hypertension? It can induce vasoconstriction and exacerbate hypertension. What is a supraglottic airway? A device used to maintain an open airway above the vocal cords. When should the supraglottic airway be withheld? If the patient is actively vomiting. How is active vomiting defined? Ongoing vomiting that cannot be cleared by the paramedic. Can a supraglottic airway be inserted if the patient has vomited? Yes, if the airway has been successfully cleared. How many attempts are allowed for SGA insertion? 2 total attempts per patient, not per provider. What is the most reliable method to confirm SGA insertion? ETCO2 waveform capnography. What should be done if ETCO2 waveform capnography is not available? At least 2 secondary methods must be used. How often should SGA placement be verified? Frequently and again at transfer of care. What should be documented regarding SGA placement? Findings and witness on the patient care record. When should the SGA be removed if the patient achieves ROSC? If the gag reflex is stimulated or the patient begins to vomit. What should be expected as the level of awareness improves? The removal of the SGA. What are the contraindications for the administration of dimenhydrinate? Overdose on antihistamines, anticholinergics or TCAs. How should dimenhydrinate be administered via the IV route? Diluted with saline. What are the 2 acceptable dilution methods for dimenhydrinate? 5 mg per milliliter or 10 mg per milliliter. What medication can be added to dimenhydrinate based on clinical judgment? Ondansetron. What are the indications for using dimenhydrinate? Motion sickness or vertigo, upset stomach due to food ingestion, hyperemesis for a pregnant patient, caused from drug interactions, head trauma. What medication should be avoided with head injuries? Dimenhydrinate. What medications should be avoided when co-administering dimenhydrinate? Diphenhydramine, anticholinergics, tricyclic antidepressants. What medication should not be co-administered with ondansetron? Apomorphine. What is the rationale for the contraindication of dimenhydrinate with diphenhydramine? Combined effect can lead to anticholinergic side effects and oversedation. What is the rationale for the contraindication of apomorphine with ondansetron? May precipitate profound hypotension. When can ondansetron be considered if dimenhydrinate is not effective? After 30 minutes with no relief of nausea and vomiting symptoms, and no contraindications. What are the negative effects of dimenhydrinate? Somnolence and confusion, especially in the elderly. Where can I find information on dangerous medications for the elderly? ISMP Bears List, https://www.ismcanada.org/bears_list/sharp L = tab 2. What is CPAP? Continuous positive airway pressure is a medical treatment for severe respiratory distress and acute pulmonary edema or COPD. When should CPAP be used? CPAP should be used for the treatment of severe respiratory distress and acute pulmonary edema, regardless of origin, or COPD. How should CPAP be used? CPAP should be considered as additive therapy to the bronchoconstriction or acute cardiogenic pulmonary edema medical directives, not a replacement. Can CPAP be interrupted? CPAP may be interrupted momentarily to administer nitroglycerin, while salbutamol can be administered via MDI port. What are the indications for a breech delivery? Confirm medical directive requirements or obtain BHP authorization. What equipment is required for a breech delivery? Appropriate PPE, obstetrical kit, cardiac monitor, SpO2. What should be done before initiating the procedure? Don appropriate PPE and gather all required equipment. What should be done to assist the patient during a breech delivery? Position the patient upright or in a supported squat position. What should be done if the legs need to be manually delivered? Apply pressure to the popliteal fossa and gently sweep foot down and out. What is the time limit for delivering the head after the umbilicus is visible? 4 minutes. What should be done if the arms need to be manually delivered? Gently sweep hand down and out if visible on fetal chest. What should be done to maintain flexion of the head? Another paramedic may apply gentle suprapubic pressure. When should the Morisot-Smellie-Veith maneuver be initiated? When the hairline/nape of the neck is visible or head does not deliver within 3 minutes after umbilicus is visible. What should be done if the head does not deliver? Maintain MSV maneuver and transport. What should be done once the head delivers? Assess and monitor adult patient and newborn for complications. What care should be provided to the newborn after a breech delivery? Provide newborn care as per BLS and ALS-PCS. How should complications be addressed after a breech delivery? Address complications in accordance with BLS and ALS-PCS. What is the Morisot-Smellie-Veith maneuver? A technique used to assist in delivering the head during a breech delivery. What are the steps to perform the Morisot-Smellie-Veith maneuver? 1. Discourage pushing 2. Support baby with forearm 3. Exert pressure on cheekbone 4. Place hand on baby's back 5. Lift the body in an arc 6. Assist the head to pivot around the symphysis pubis 7. Allow face to deliver 8. Ensure controlled delivery of the head. What are the signs of imminent breech birth? Fresh dark meconium at perineum breech, foot/leg visibly protruding from vagina. What are the complications associated with breech birth for the fetus? Nuchal cord prolapse, hypoxic damage and asphyxia, damage to internal organs, fracture of humerus, clavicle, femur, and spine, dislocation of hip or shoulder, head and neck trauma, limb presentation, death. What are the complications associated with breech birth for the adult patient? Placental abruption, premature separation of placenta, patient trauma, postpartum hemorrhage. What should be done if there is a limb presentation during breech birth? Cover limb with dry sheet. Watch closely for progression of delivery/birth. Place patient in anti-gravity position. What should be documented during breech birth? Breech visible on the perineum. Time umbilicus is visible. Manual release of legs, manual release of arms. Time hairline is visible. Morisot Smellie-Veet maneuver. Time of birth of baby. Time of delivery of placenta. Amount of bleeding, minimal/moderate/large amount/clots. What is shoulder dystocia? Complication during childbirth where the baby's shoulder gets stuck. What are the indications for managing shoulder dystocia? Confirm medical directive requirements or obtain BHP authorization. What equipment is required for managing shoulder dystocia? PPE, obstetrical kit, cardiac monitor, airway equipment. What is the first step in the procedure for managing shoulder dystocia? Don appropriate PPE. What should be done before initiating the procedure for managing shoulder dystocia? Gather all required equipment. What should be done if signs of imminent shoulder dystocia birth are present? Assess for signs and inform patient and support persons. What should be done after informing the patient and support persons about the emergency situation? Explain the procedure and obtain consent. How should the patient be positioned for managing shoulder dystocia? Supine on the edge of a firm surface, if possible. What is the time limit for completing delivery after the baby's head is delivered? 8 minutes. What should be done if the first alarm maneuver is unsuccessful? Paramedic partner performs alarm maneuver. What should be done if the second alarm maneuver is unsuccessful? Transport immediately and perform alarm en route to the hospital. What should be done if there is a successful delivery of the baby? Assess and monitor adult patient and newborn for complications. How should newborn care be provided after a successful delivery? In accordance with current BLS and ELS/PCS. How should complications be addressed after a successful delivery? In accordance with current BLS and ELS/PCS. What are the 5 interventions of alarm maneuvers? ask for assistance, like subduction, adduct shoulder, roll patient, manipulate fetal position. What should be done during the intervention of alarm maneuvers? Ask patient, spouse/family/healthcare professional, and paramedic partner for assistance. What should be done during the intervention of alarm maneuvers? Hyperflex hips by lifting legs and knees, aiming to bring knees to ears and form a squatting position. What should be done during the intervention of alarm maneuvers? Apply suprapubic pressure to adduct the shoulder. What are the other two interventions of alarm maneuvers? Roll patient and manipulate fetal position. What is suprapubic pressure? Pressure applied above the pubic bone to assist delivery. What is the purpose of maintaining suprapubic pressure throughout the entire contraction? To help guide the baby's shoulders through the birth canal. What is the Gaskin maneuver? A position where the patient rolls over onto hands and knees. What is the purpose of applying upward lateral flexion of the baby's head during the Gaskin maneuver? To facilitate the delivery of the baby's body. How should the posterior arm be manually released? Follow the humerus, sweep the arm across the fetal chest, and deliver the posterior arm. What are the signs of imminent shoulder dystocia birth? Slow emergence of the baby's head, difficulty sliding the chin over the perineum, retraction of the head against the perineum, cyanosis to the baby's head, failure of spontaneous restitution, and failure to deliver shoulders with expulsive efforts. What are the complications associated with shoulder dystocia birth for the baby? Clavicle fracture, humeral fracture, brachial plexus injury, pneumothorax, hypoxia/asphyxia, and death. What are the complications associated with shoulder dystocia birth for the adult patient? Postpartum hemorrhage, extension of laceration into the rectum, vaginal laceration, cervical tears, and uterine rupture. What should be documented during a shoulder dystocia birth? Color of fluid, time of birth of head, presence of turtle sign, time of each maneuver and attempt to deliver the baby, time of other paramedic attempting alarm, and time of birth of baby. What is the time of delivery of placenta? The time when the placenta is delivered after childbirth. How is the amount of bleeding categorized? Minimal, moderate, large amount, or presence of clots. What are the indications for an uncomplicated childbirth with nuchal cord and placental delivery? Confirming medical directive requirements or obtaining BHP authorization. What equipment is required for an uncomplicated childbirth? Appropriate PPE, cardiac monitor, obstetrical kit, O2, pediatric resuscitation equipment. What is the first step in the procedure for an uncomplicated childbirth? Don appropriate PPE. What should be done before initiating the procedure for an uncomplicated childbirth? Gather all required equipment. What should be done to provide comfort during an uncomplicated childbirth? Provide warmth and adequate lighting. How should the patient be positioned during an uncomplicated childbirth? Supine on a firm surface with head and shoulders slightly raised, legs flexed and abducted at hips and knees. What should be done to visualize the perineum during an uncomplicated childbirth? Guard the perineum with a 4x4. What should be done if the patient's membranes have not ruptured during an uncomplicated childbirth? Observe for rupture of membranes and note the color of fluid if possible. How should the head be delivered during an uncomplicated childbirth? Deliver the head in a controlled fashion and apply gentle pressure to control delivery. What should be done once the head is delivered during an uncomplicated childbirth? Allow restitution of the head to occur naturally. What should be done if a nuchal cord is present during an uncomplicated childbirth? If the cord is loose, slip it over the baby's head. If it is tight, clamp and cut the cord. When should the patient be encouraged to push during an uncomplicated childbirth? With the next contraction or sooner if restitution has occurred and the patient is ready to push. How should the shoulders and body be delivered during an uncomplicated childbirth? Gentle lateral flexion followed by gentle upward flexion. Where should the newborn be placed after delivery during an uncomplicated childbirth? Directly onto the patient's abdomen, prone with head to the side. What should be done after the newborn is delivered during an uncomplicated childbirth? Try, stimulate, and assess the newborn for tone, breathing, and crying. What should be done to maintain warmth for the newborn after delivery during an uncomplicated childbirth? Cover the newborn with a new blanket/towel. What should be noted after the delivery during an uncomplicated childbirth? The time of delivery. What should be done to provide a clean surface during an uncomplicated childbirth? Place a plastic sheet/bag/towel/drape under the patient's buttocks. What should be done to obtain consent during an uncomplicated childbirth? Explain the procedure and expected outcome to the patient and obtain consent. What is the recommended time to allow the cord to pulse before clamping and cutting? At least 2 minutes, unless neonatal resuscitation is required or multips are known or suspected. How should the umbilical cord be clamped? In 2 places approximately 15 cm from the infant's abdomen, and approximately 5 cm apart. What should be used to cut the umbilical cord? Sterile scissors. What should be assessed for after delivery? Placental detachment. How should the uterus be guarded during placental delivery? Place a hand on the lower portion of the abdomen, just above the symphysis pubis in a cup position. What should be done with the other hand during placental delivery? apply gentle controlled cord traction using up and downward motion, working with the patient's contractions. What should be done when the membrane trail is seen during placental delivery? Ask the patient to cough or laugh and gently tease out the membranes in an up and down motion until completely delivered. What should be done after placental delivery? Perform external uterine massage. How should the placenta be handled after delivery? Place it into a provided plastic bag and transport it with the mother and newborn, labeling the bag with the patient's name and documenting the time of delivery. What are some complications/considerations during delivery? Nuchal cord, prolapsed umbilical cord, malpresentation, shoulder dystocia, postpartum hemorrhage. What is manual defibrillation? A procedure to deliver an electric shock to the heart to restore normal rhythm. What are the indications for manual defibrillation? Confirming requirements and obtaining authorization. What equipment is required for manual defibrillation? PPE, airway equipment, towel, O2 source, cardiac monitor, razor. What is the first step in manual defibrillation? Donning appropriate PPE. What should be done before applying defibrillation pads? Confirming patient is VSA and initiating CPR. What should be done after applying defibrillation pads? Entering manual mode and stopping CPR. What should be done for a non-shockable rhythm? Checking carotid pulse and taking appropriate actions. What should be done for a shockable rhythm? Restarting CPR, ensuring proper joule setting, charging defibrillator, delivering shock. What should be done after delivering a shock? Immediately starting CPR with no pulse check. How often should the patient be reassessed during manual defibrillation? Every 2 minutes as per monitor prompts or medical directive. What complications/considerations should be kept in mind during manual defibrillation? Ensuring proper placement of defibrillation pads and being aware of potential skin inflammations and burns. What should be done if the required joule setting is not available for pediatric patients? Increase to the next available joule setting. How often should compressors be rotated? Every 2 minutes, if possible. When should CPR be stopped? When the patient shows signs of life. What may happen to the rescuer/bystander if they are touching the patient during defibrillation? They may experience electrical shock. What should be considered in airway management?